So, good morning, everyone. Bienvenue à notre mardi scientifique. Today, I'm very happy to present to you today presenter. We have Dr. Joseph Sadek. Dr. Joseph Sadek will talk to us about suicide and suicide prevention. Dr. Joseph Sadek is a medical doctor. He has a Master of Business Administration. He has a Bachelor of Pharmaceutical Science, Fellow of Royal College of Physician and Surgery of Canada. He was also a diplomat of the American Board of Psychiatry and Neurology. Dr. Sadek works as a full professor of psychiatry at Dalhousie University. He serves as the clinical and academic leader of Nova Scotia Health Acute Care and directs the Atlantic ADHD Center in Nova Scotia. Additionally, he leads the psychopharmacology consultation service at Nova Scotia Health. Dr. Sadek is the chair of the Education Committee at the Canadian Psychiatric Association and sits on the Royal College Subspecialty Committee in Psychiatry. He has previously served as Vice President of CADRA and remains active member of its advisory board. Dr. Sadek completed his psychiatry residency at Dalhousie University, followed by a psychopharmacology research training at the Global Clinical Scholar Research Training at Harvard University. He is also an editor of a brain science MDPI journal. As an author, Dr. Sadek has published 5 books and 76 academic papers. His work has been recognized with numerous awards and grants, including honors from Government of Nova Scotia House of Assembly for his contribution to suicide prevention, and an award of merit from the Commonwealth Judicial Institute for his service to the judiciary community. Additionally, he received the Education Award in 2023 and 2024 from Dalhousie Medical Schools. Dr. Sadek, thank you for accepting the invitation. Mesdames et messieurs, please join me and welcome Dr. Sadek. Dr. Sadek, the stage is yours. Thank you.
Merci bien, thank you very much. Je suis très heureux de parler avec vous aujourd'hui de suicide, prévention de suicide. I am honored to be here and thank you very much for attending. This is my disclosure statement, my book royalties. I'm hoping at this end of this session to describe some aspect of suicide prevention that could be valuable to clinicians. I really have an ambitious agenda to try to cover some of the different areas. So I want to cover a little bit about the challenges of suicide risk assessment, about our tools that we use in Nova Scotia that we currently use, the arguments against suicide prevention. I want to talk about suicide in the elderly, and I think that I'm happy to present to you a paper that I wrote in 2024, a review article to talk about that. And then finally, I'm going to talk about artificial intelligence and suicide, because I think that's an important topic. So I'm hoping we could finish all that. And in the middle, we'll have questions after, specific sections. Please let me know if you can hear me okay. Can you hear me okay, Dr. Ibrahim?
Yes, everything is perfect.
Thank you. So why suicide prevention is important? I'm sure we all agree that the psychological, social impact of suicide on families and society is immeasurable. On average, single suicide affects at least 6 other people. And if it happens in school or workplace, impacts hundreds and hundreds of people. In general, the burden of suicide is twice the burden of diabetes, equal to the burden of birth asphyxia and trauma. A huge burden that suicide puts on everyone. Not going to spend a lot of time in epidemiology. Basically, we had the range fluctuates every year, but we had, for example, in 2019, we had 4,012 cases of suicide. We have the rate, 17.9 versus 5.3 in 100,000 ratio between suicide rates for males and females. And all age groups are impacted, but the highest age group, 40 to 59, had the highest rates. And unfortunately, in Canada, the rates in indigenous youth is the highest in the world. It's about 11 times the national average. You can see the distribution of age groups and the suicide from Statistics Canada. We had to have a suicide prevention task force in Nova Scotia, and I was the chair of that task force. What we needed to do is to meet accreditation of Canada standards. We wanted to review the current and past morbidity and mortality data. So we looked at every case of suicide, what happened. In a non-judgmental way, we just wanted to understand if there's anything that could have been done differently. What do we learn from the morbidity and mortality cases? We did we had a group of 12 people doing literature review related to suicide, identifying the challenges in suicide risk assessment. And then finally, we designed a tool that's just a simple tool that's to put all the information together in one piece of paper. And I'm going to show you that tool. It's nothing fancy or not a scale, diagnostic scale or standard rating scale. It's simply just a tool to help clinician put all the information in one place. As you know, there are ROP, required organizational practices. We have one in by Accreditation Canada that they wanted client at risk of suicide identified. The risk of each client is assessed at regular interval. Treatment and monitoring strategies are identified. Implementation of treatment and monitoring plan documented in the client record. And this documentation has been a problem because in many cases, there weren't enough documentation. And when cases went to the court, unfortunately, there was some difficulty because we didn't have enough documentation. So what are the common challenges in suicide risk assessment? I think we have lots, but clinicians rely on subjectively reported information, and sometimes that doesn't always provide a full picture. We need collateral information. So in our tool, we included that we have to put a piece there for collateral information obtained. Suicide risk assessment scale do not accurately predict death by suicide and really can't be used for suicide risk assessment in people not trained in on these tools. So that was another issue. And if you look at all the reviews, systematic reviews on suicide risk assessment scales and tools, you would find that there is so many difficulties with each one of them. Then we had lack of consistency in education and training of healthcare providers. Some people are trained very differently in suicide risk assessment. And so we said we have to develop a training program that applies to everyone and try to have video modules, ebooks, books, face-to-face training to make sure that everybody is exposed to the same training. And then suicidal behavior can produce very intense emotional response in some clinicians. And when these emotional responses are unrecognized, they could create negative reactions that limit the ability of the clinician to work effectively with patients who are acutely suicidal. And so we said that we are going to tackle that in our training. The documentation, as I said, sometimes suicide risk is not documented and not communicated with others involved in patient care. And I'm going to talk a little bit about that area in the next section coming in terms of communication. We also sometimes acute risk can be not differentiated from chronic risk. So some people who are self-harming but suddenly they are acutely suicidal, so they needed some specific management. So we did a module on self-harm and acute on chronic kind of presentation, and did a lot of work also on borderline personality disorder. Then some people argued that suicide prevention is not the responsibility of the mental health system. And we tried to look at the literature. Is it really our responsibility or not? So several researchers found that majority of patients who died by suicide had a mental disorder pre-existing. Mood disorder, substance use disorder, those are the top 2/3 of people who died from suicide. And then personality disorder accounted for an additional 15%. So we had three major causes that relates to us. So we felt that, you know, truly that yes, there are some social dimensions that we shouldn't ignore, but at least we have 2/3 of those people who died by suicide, they had a mental disorder that can be treated, or you know, maybe the outcome could be changed. We don't know, but at least that's what the research tells us. And then the other argument is that no evidence that suicide prevention can be successful. So we actually have evidence that some suicide prevention was successful. I have to tell you three places that had very good suicide prevention programs. University of Akita in Japan, after 4 years on working on suicide, they reduced their suicide by 50% after 4. This was one of the highest suicide rates in the world, and they were successful to reduce in half after 4 years. UK had a program for the inpatient particularly, and they were able to decrease the rate by 20% in 2 years. In Germany, in Nuremberg, after 2 years, the program resulted in 24% reduction in actual total suicide and suicide attempts. So do we have evidence that there are some success? Yes, I think we do. Then the arguments continue. They say psychological autopsies are flawed theoretically, methodologically, analytically, that, you know, we can't rely on psychological autopsy. But other sources, we respond and say other sources such as emergency room data, the coroner's reports, the confirmed presence of mental disorders. And several cases of suicide were reported during hospital stay or post-discharge from hospital. So we have documents telling us that, you know, there was a mental disorder. And another argument is that there are real differences between suicide rates of different nations. And so they say, well, maybe this is due to socio-cultural differences and not due to prevalence of psychopathology. But if you look at it, we could also think that maybe it's attributed to different recording strategies, different approaches in suicide risk management in different countries. And the large national register studies in many countries demonstrated number of significant socio-demographic and clinical features utilizing the PAR, which population attributable risk statistics, which is singularly appropriate for suicide as it has potential to place risk factors in the population level, and the overwhelming majority showed that there is a mental disorder, even in those countries. The gender ratio, they are saying, well, if the gender ratio of is 3-1, you know, but this is different than the actual prevalence of mental disorder in many cases, which is 1-1. But we say, well, there are more attempts that happens in females, so really we can't rely just on that ratio. And finally, they said we can't predict individuals who will die by suicide. Yes, probably we can't. But that doesn't mean that we don't take patients seriously. That doesn't mean that we assess their suicide risk level. And here our role becomes very important. The social issues cannot be ignored because yes, we understand that there is a significant social impact to, social change can be important. And we are saying this lobbying should not be done at expense of good clinical care. Research shows that changing social factors lower suicide rate in some cases, but research also shows that treating mental disorders and therapeutic risk assessment, just by doing a therapeutic risk assessment, it has a good impact on the outcome. So this is our in Nova Scotia, we had some, a policy for suicide risk. We did the introduction to the literature. We talked about the content of the suicide risk assessment. We formulated the risk management, and we came up with such a small tool that has, interview risk profile, illness risk factors, individual risk factors, support issues, and then the risk buffers. And then the two important areas were communication plan. Did we talk to somebody else in the team about this, including like a nurse, a physician, mobile crisis, others? And then what is the management plan? And then we documented the risk level, and we wrote a note to say, why do we think this risk is important? And now, when these cases goes to court and we have this tool, then we have some kind of a degree of documentation of what's going on. So the third part of the challenges is psychotherapy. And with the analysis of the morbidity and mortality cases, and then looking at different literature about psychotherapy and suicide, we found that like there is five main problems that happens in psychotherapy with suicidal patients. Now, if we could avoid those five problems, maybe the outcome could be better. This is a nice study that I want to bring to your attention that was by Hendon and published as American Journal of Psychiatry. Case studies of 36 patients who died by suicide while receiving open-end psychotherapy, 25 males, 11 females. It involved 29 psychiatrists, 5 psychologists, 2 social workers. So the first problem they identified in the analysis was the lack of communication between therapists. So I see a patient, the social worker or the psychologist is seeing a patient. We don't talk to each other. And sometimes I have very valuable information that if I have passed on to the other therapist, maybe the outcome would have been different. So, and also communication between current and the previous therapist. So those are also two very important issues. And 23 patients out of those 36, they seen another therapist during the 6 months beginning which they died, and there was no communication between the current and previous therapist. And in some cases, patient was hospitalized just before suicide, and there was no communication between the outpatient team and the inpatient team. And maybe if there was a communication, things would have been better. Were several cases where psychologists or social workers were providing psychotherapy, psychiatrists was managing medication, and the team had electronic access to each other's treatment, but they didn't review those notes, and there was no communication directly between those two, the two teams. The second problem that was identified in this was permitting patients or their relative to control the therapy. And so in some cases, patients frequently control the therapy, sometimes using the threat of suicide to do that. Well, these are the conditions for me to continue therapy. You do this, I continue therapy, otherwise I would kill myself. And unfortunately, that was, in some patients, certain conditions of living, and insisted on therapist support in meeting these conditions. And the therapist complied, thinking that by doing that, will keep the patient alive. Unfortunately, it wasn't. They even controlled the amount of, or if they should take medications or not, and to keep them alive. And that was another way of controlling the therapy. Finally, in 2 cases of those 36, the mother is pressured against better judgment of the psychiatrist to discharge patient prematurely, and the patient died by suicide. So in all of these cases, patients' ability to work in therapy was seriously compromised, but the therapist felt that they had no choice but to go along, even in few cases where patients stopped taking medication altogether. The third problem identified in the literature, which is ineffective or coercive actions resulting from therapists' and anxiety. 5 cases, the therapist of an eminently suicidal patient suggested hospitalization, but left the decision to the patient. And in each case, it was rejected, and the patient took their life shortly after. The next issue has been not recognizing the meanings of patients' communication in psychotherapy. And in some cases, the therapist failed to recognize the meaning of the patient's communication. The therapist misunderstood or took it too literal that the patient were saying, you know, and they couldn't recognize the suicide crisis that they are going through. And if you go back to this literature, they have beautiful examples of this. It's a really nice one, one of the nice pieces of literature that's very useful. And the last issue that we also reviewed in morbidity and mortality was the untreated or undertreated symptoms. So major symptoms related to substance abuse and anxiety, psychosis were not adequately addressed, and some patients in whom obvious substance abuse not treated. So those were the 5 areas. I'm going to review them again. The first one was lack of communication between therapists, or between the outpatient team or the inpatient team, or between the treating psychologist and the treating psychiatrist. That lack of communication was very problematic. Number 2 was permitting the patient or relative to take control of the therapy. Number 3 was the ineffective or coercive actions resulting from therapists' and anxiety. And number 4, not recognizing the meaning of patients' communications. And that was a very big one. And number 5, untreated or undertreated symptoms, that there was a room to treat the symptoms were not treated, and some people died because they couldn't tolerate their symptoms anymore. And particularly substance abuse and anxiety and psychosis. So that we now covered the challenges in suicide risk assessment. We also tackled the arguments against suicide risk assessment and whether this is our responsibility or not. We talked about the tool that we had in Nova Scotia. And then we talked about other challenges, which is challenges in psychotherapy. Now, the fourth challenge is in suicide in older adults. And that seems to be a growing problem. I was lucky to be involved with a group of great researchers here, and we published this paper, Suicide and Suicidal Behavior in Older Adults. It came in April 2024, and it's available free at the Frontier Psychiatry. So you can, if you feel you want to read it, feel free to download it. It's a review. And we looked at common risk factors for suicide in older adults. What are the common risk factors for suicide in older adults? Social isolation, social problems, family conflict, perceived burdensomeness, lack of meaning in life, limited social connectedness was very big and repeated in the literature over and over and over again. Then, of course, psychiatric disorder, particularly like, for example, the MDD, previous, suicide attempts. Alcohol use was very problematic, and substance use as well. Physical health problems such as cancer and physical pain, and reduced functioning and autonomy, in addition to numerous other factors. Depression has long been associated with increased risk of suicidal thoughts, suicide attempts. Presence of depression in geriatric patient is no exception. There are unique findings in patients of advanced age, one of the most prominent being perceived burdensomeness. So I feel I'm a burden. I shouldn't be here anymore. I'm burden to my kids. I'm burden, and that can be, it was repeated in 2014, 2016, 2019, 2022. In many literature, this has been a very consistent risk factor. Interestingly enough, symptoms of depression, as you know, frequently detected in early stage of asymptomatic Alzheimer's disease. And the stage of neurological decline that precede dementia, which is the mild cognitive impairment, MCI, has been found to be concurrent with depression in old age individuals. And the incidence of depression in late life is a vital predictor of the progress of the mild cognitive impairment to go to become a moderate to severe cognitive impairment. So this incidence of depression. And the patient diagnosed with dementia generally have an elevated risk of suicide. And recent research suggests that risk of suicide increases within 1 year after the diagnosis of dementia. This piece of information is very important. So recent research suggests risk of suicide increases within 1 year after diagnosis of dementia. Cannabis and suicide is another problem. As you know, baby boomers generations, they have higher rates of marijuana illicit drug use compared to other generation. And as the THC content of cannabis increases, adverse effects increases, worsening cognitive decline and the medical condition, interaction with other meds, the risk of falls, and increase the risk of depression and suicidal ideation. There is a linear association. The risk of having depression or suicidal ideation was linearly associated with marijuana use frequency, and frequent use of marijuana increased suicide risk in more than one study. And possibly, there's different theories why that is the case, but possibly through increased impulsivity, decreased inhibitory control. And so one of the recommendations of the literature was to have primary care screen for drug use in older adults and identify, alcohol and substance use in older adults. Alcohol was the second most common diagnosis among older adults who died by suicide. Increased the risk of suicide in both men and women, and has a greater negative effects on older adults because of the slower metabolism, higher blood alcohol levels with the changes in metabolism in the elderly. Now, medical illness obviously is a major problem. So chronic health condition, mobility impairment, limitations in activities of daily livings, your ADLs and your IADLs can exacerbate feelings of hopelessness, despair, increasing vulnerability to suicide. Functional disability may act as a barrier to seeking and receiving appropriate mental health care, further compounding the risk of suicidal behavior among older adults. So this is a major issue. Those, people who started having chronic health condition, mobility impairment, limitations of my ADLs, I can't dress myself anymore. I can't feed myself anymore. I can't use the toilet properly, you know, hygiene, transportation. All of these issues can become a problem. Another very important area we need to pay attention to, which is loss of a partner. So, loss of a partner heightened suicide risk and has been identified as a significant risk factor for suicidal behavior among older adults. So, of course, personality traits could still, have a role in as a risk factor as well. COVID-19 had interesting results. So suicide rates significantly increased in adolescent males, adults, and older adult females. In women 65 or older, suicide rates increased by 12.5% after COVID. This was a very large study in 2022. Interesting, can't really explain it, but were the findings. Another very interesting thing is the previous suicide attempts. The higher risk group, if you had a previous suicide attempt, it's the age group between 65 to 74. But if you are 75 or older, actually having a previous suicide attempt does not increase your risk. Again, why? No idea. So some strategies to mitigate suicide, they were suggesting four main kind of strategies. And the first domain consists of integrating intensive screening protocols in primary care settings. So for the elderly, depression screening, management in primary care settings, particularly in collaborative care, has the strongest evidence repeatedly. So what do we need to do? We need to screen. What do we need to screen for? We need to screen for, depression, alcohol, substance use disorder, risk factors. The second, modifying the society's approach to aging, because this normalization of depression among older adults is not good. So we need to change that attitude that this is, yeah, he's elderly, he's depressed, it's okay to be depressed. We don't need to do anything about it. No, we do need to do something about it. The third approach relies on furthering existing research on how the symptoms present differently in this population. So the warning signs can be made aware to the public and to the healthcare professionals and workers. So those warning signs in the elderly could present differently, and we need to do more research on it, and we also need to produce more awareness about them, to tell people and tell the public and tell our healthcare professionals and workers about them. And then the fourth dimension entails implementing accessible supportive resources for older adults, such that they don't feel isolated, have outlets to discuss their feeling, and rather, having them dismissed. So I think that lots of older adults, they have nobody to talk to, they feel isolated, they feel, they are a burden, and they have very little support. I don't know in Quebec how it is, but here it's quite difficult. if the patient is not admitted, suicidal patients was, clinicians should be able to provide some recommendations for age-appropriate outpatient resources, facilitating access to emerge if needed, or suicide hotlines or first responders, and facilitate interpersonal connectedness in the patient's community through advocacy, liaison with other family members, familiarizing with community program, because lots of people, there are community programs, but they are not aware of these community programs. So those are all helpful things that can be done. In terms of medication, we have evidence for lithium, clozapine, and ECT. Now, ECT has been wonderful in for many reasons. Number one, ECT works quickly, and we can use a bilateral treatment um, versus ultra brief right unilateral treatment. As you know, the pulse width is the controlling factor here. So the bigger the pulse width, the more cognitive side effects. So we used to have a 2 millisecond pulse width in ECT. We reduce that now to 1 millisecond in bilateral treatment. In ultra brief right unilateral treatment, we use only 0.3 milliseconds. So now you can imagine how much of the decrease in the pulse width has been helpful to minimize the cognitive side effects, which was our main kind of concern at that point. So now we are able to use the ultra brief right uni, or even with the bilateral treatment, which is quite effective, and with 1 millisecond pulse width. As you know, we can only change the pulse width, the frequency, and the duration to adjust for the amount of energy that we give to the patient, and we usually stick to maximum of 100 joules. So in ultra brief right uni, we only use 0.3 milliseconds. Decrease pulse widths to lower the cognitive side effects in the elderly, but we have evidence that ECT is effective in suicidal patients. We still emphasize that predicting suicide is quite difficult, and in some cases it's, um, the what really needs to happen is to actually put all the risk factors together. So which includes imminent risk factors. I have a plan now, I want to die now, I have a mean to do it now. And then the other risk factors, as you mentioned, I feel I'm a burden, I'm not, I have no, lack of support. I am perceiving my cognition. Have a very negative cognition about myself and about others. And then I'm also going to look at their physical health issues. I'm going to look at their psychiatric diagnosis and previous psychiatric history. I'm going to look at their medical history. I'm going to look at their previous attempts. And I'm going to look at some of the resiliency factors. And then, based on looking at all the factors, and I'm also going to look at my intuition, how am I feeling about this, and put all the factors together and come up with a risk level and say, well, okay, I feel that this patient is really at imminent risk of suicide, and I think I'm going to admit this patient as an involuntary patient. But after I did kind of look at all the factors that I'm thinking of, the current interview factors, the history factors, the family factors, the social factors, all the possible risk factors, put all of that together and come up with a decision. So in general, they found that, for example, impulsivity in ADHD increases the risk of suicide, but we don't have a very solid research on the impulsivity as a trait and the effect of that in general. We have impulsivity increase the risk, but that's a smaller kind of increase, and within the global kind of assessment, we need to take all the other factors also in addition to the impulsivity. But certainly impulsivity has shown to increase to heighten the risk in some patients. And we know, for example, people that are, intoxicated and they lack inhibition, they do more impulsive things while, during that time. So the risk increases that way as well. Poor judgment, increased impulsivity, all these factors. So we are really, all we are asked is that we just, we did our work, we documented our work, we can't control the outcome, but we just, and when the court looked at several cases, it wasn't about the outcome, it was about the process. And I think it's we do our assessment, we do our job, we document our findings. That's all we can do. That's all we can do. We might never be able to prevent a case, but we can do what the maximum we can do. And I think that is, important to recognize. I think that this is a very difficult area. This is a very, very difficult area. And as you mentioned, the risk would change very quickly. So can we control that? That's, that's very difficult to predict, if I understood it correctly. The main issue, do I feel that there is an imminent risk here or not? Is there an imminent suicide risk in this case or not? And imminent, like I feel like after I finish this assessment, within the next 24 hours, this patient's gonna die. If I get that feel, then that's, I probably would admit that person right away.
Thank you.
Thank you.
We have only 6 minutes left.
Okay.
Sorry for the
All right. So AI and suicide. Artificial intelligence, that's a very interesting and important topic. We have machine learning and we have deep learning that have shown greater potential to enhance suicide prediction and prevention. Machine learning is a subset of AI that involve algorithms, statistical models, that can automatically learn complex patterns from large data sets. Instead of relying only on human written rules, the machine learning algorithm self-optimize, analyzing large amounts of data over time. Then the deep learning can be considered a specialized machine learning method based on artificial neuronal network, the ANNs, which can learn from multiple layers of representations. And then we have the natural language processing, the NLP, which enables the computer to process and analyze human language data automatically, allows the mining of unstructured textual data like clinical notes, online posts like Facebook posts or something, speech transcript, to extract insight related to suicide risk from all of these. That's the natural language processing. And so it can identify emotional distress cues, interpersonal concern, hopelessness, other warning signs, And these gives a possibility to study the context, history, analyze suicidal thoughts, know the location, the contacts, the possible to build models that can offer support and assistance to such individuals. Very, very interesting area. The main goals of ML studies in suicide, we have several studies actually so far. They wanted to improve the accuracy of risk prediction. They wanted to identify important predictors and interaction between them and to model subgroups of patients. They want to, like, cancer subtypes, we want to have subgroups of patients. I think it's a great opportunity for more work, but at this point, we have a lot of limitations. Why? Because the methods they used, every study is different. And the quality of the study is different. And then there is incomplete reporting of the statistics, the area under the curve, sensitivity, specificity, all of these were really, when you look at different studies, you can't really put them all together. And then the key parameters such as the positive predictive value, area under the curve, the lead time of prediction, which allow for decision making about potentially act, intervene, which is also underreported. And this is really important. I want to know, when am I going to act? Am I going to make a decision today, tomorrow, in 48 hours? I want a computer to tell me that, but they couldn't. And there's a high number of studies using EMR, and that raised the concern to bias due to EMR data. It's collected majority at hospital visits, incomplete records, missing data, consideration relevant to accurate coding, and most studies were cross-sectional in nature, underscoring the need for prospective design MLA investigation to advance suicide risk predictions. So that ends my talk, and I'm happy to take any other question. Thank you so much for learning. Merci bien. And je vais essayer de répondre aux questions.
Thank you, Dr. Sadek, for this excellent presentation.
Thank you.
We will